Welcome to the Concussion Fix podcast, where we lift the veil on concussion recovery and empower you with real answers to real questions about persistent concussion symptoms.
Welcome to this week's episode of Concussion Fix. Today's podcast, we're going to go over a question we were asked in our live Q&A about Tylenol and if it should be used during PCS recovery. So I think first we'll go to Dr. Herkel. Love to have your ideas on Tylenol and Advil, if they should be used for acute pain, chronic pain, and kind of your thoughts around that.
Yeah, great question. It's probably one of the most common recommendations that people that have just sustained a concussion are given. They usually go to an urgent care clinic or they go to the ER, and then they have all the scans to make sure they rule out all the big red flags like a brain bleed. And then they're given the diagnosis of a concussion and then told to go home and rest, and just it'll go away. It'll resolve itself after a couple days. We know that those concussion literate people, that sometimes that doesn't happen, but in most cases, 70% or so of cases, it does. And so a lot of symptoms that they have are pain related and had things like headaches and neck pain. And so they'll be given the recommendation from docs in the ER or their family doctor just to use pain medication over the counter, like something like Tylenol or something like a non-steroidal anti-inflammatory to manage that type of pain. Tylenol is an analgesic, so it blocks pain, where something like Advil is an anti-inflammatory. So it has, both of them have anti-pain effects, but slightly different mechanisms of action. So I think that these class of medications are very helpful for acute pain, especially pain that kind of will resolve after the acute phase. Like, let's say you sustain fever or infection, help bring down fever. Both these medications can be helpful with that. But there's a normal kind of natural process for that resolution in a couple days. With concussion, sometimes symptoms can become chronic, and definitely in persistent symptoms, there's a strong kind of resistance from pain doctors and neurologists to prescribe this class of medications because they're not really a long-term solution. They're meant to be used sparingly in acute situations. So I think that makes sense acutely, but not so much in persistent symptom situations. And the other thing to consider is that there are some detrimental effects to using these medications, especially used consistently. This is not really an issue if you're using it, for a headache that comes on after a concussion for a couple days just to kind of manage the symptoms, but then the use goes down. And there's definitely some dosage recommendations, especially with Tylenol. There's a definite liver toxicity factor. And the reason it's liver toxic is because it depletes this substance called glutathione, which actually has a lot of neurological benefit in the long run for protecting nerve cells, for protecting different cells from the inflammatory and oxidative processes. So we definitely don't want to be taking a medication like Tylenol that will deplete this, especially up to that kind of like max dosage of like 4 grams a day. The higher the dose, the more depletive it is. So I think that the potential here with using these medications after a concussion is that it can be helpful short term, but then if a person becomes reliant on it, even over the span of a week or two, you can actually get some of this glutathione depletion, and also you get what's called a rebound headache. And I know, Cam, you and I have talked about this with some of the patients that we've shared. We've seen this as a potential reason why people have persistent headaches, because they've just been stuck on this cycle of using these analgesic medications, and then you're going to get more symptoms every time you come off them. So it's a Band-Aid solution. It can be a short-term kind of step, but definitely I think long-term it can be problematic. What do you think?
Yeah, no, I agree. I think that a lot of times people, they got a headache, they'll go for some Advil or they go for some Tylenol, and, it helps their headache, and great.
Mhm.
But then it wears off, and then your headache's back, and then you go, okay, I got to go back for the Advil and Tylenol. And people don't really get the full picture as to what the like long-term kind of negative impacts of this are, right? Like if you use Tylenol daily for a while, now you develop this rebound headache, which is actually like a withdrawal symptom.
Yeah.
So when you don't have the Tylenol in your system, you have a headache. And so now the difficulty becomes figuring out whether or not this headache is due to some sort of persistent concussion symptom or whether or not it's actually just withdrawal from the Tylenol. And now it creates a confusing picture, right? And even if you think about Advil, it's like, well, Advil is an anti-inflammatory, quote, and inflammation is one of the drivers of persistent symptoms. So why wouldn't I want to take Advil to reduce my inflammation? Well, a lot of inflammation comes from gut dysfunction, and Advil actually causes increased gut issues. And so in the short term, yeah, it can alleviate your pain, but in the long term, you're actually creating more of an inflammatory response because of the gut dysfunction that chronic Advil use can result in, right? So I think that, you hit the nail on the head where for the short one-off, oh, you get a headache, once every month and you take an Advil to help it, it's fine. But when you have chronic daily headaches, it's better to try and figure out why you have those headaches rather than just trying to like continuously mask it, right? And it becomes difficult because people have to live their lives, right? People have to get through. And that's often the response we get is, well, like I have to work. I can't take time. I have to like be able to get through my day. And the only way I can do that is by using these medications. So it's a challenging situation that people find themselves in. And ultimately, like with the concussion fix, like what we're trying to do is let people figure out why that headache is there, right? Because the headache is there for a reason, right? Blocking the pain response is not treating the headache. It's just it's just numbing the symptom.
Yep.
But really, ideally, you want to get to a point where you're treating the underlying cause of that pain, of that headache. And so I think that's a much better long-term solution is like if you address the cause versus just masking the symptom. And unfortunately, like the way our medical system works, it's all about symptom masking, right? It's like, oh, you're depressed? Here's an antidepressant. Okay, but let's explore why we have depression. Let's try to get to the root of that. And like that's a long-term solution. And I just think that, this is people have gotten so used to just taking a pill for this or a pill for that. It's an easy, simple, okay, I take this and it's done. But, you gotta kind of do some of the groundwork to really create a long-term, solution to that. And headaches might be due to autonomic dysregulation, right? They may be due to inflammation, as we already talked about, which is generally related to like gut, diet, sleep, exercise levels. Autonomic is also included in there. It may be a neck issue, right? Some good neck treatment can actually alleviate that headache, and that's a much better long-term solution than taking medication. So, and I actually mentioned in the session, I said it's kind of like short-term gain for long-term pain, because in the short term, yeah, it feels good to do that. It's a simple solution. You can knock your headache out in, 20 minutes. It's resolved and feels better. But in the long term, you're actually just kind of keeping it around by not addressing that root underlying cause. So I think a better solution is to try and get to that point where you get the cause.
Yeah, so while people are addressing those root underlying causes, trying to figure them out, um, working on all the things that you mentioned, what would be some things that they could maybe reach for or try and do instead of reaching for the Tylenol, Advil, those types of things instead?
That's a good question. I'm going to leave that to Paul.
Yeah, it's a great question because I think that's obviously the next thing that anybody listening to this would be thinking. I think I want to reiterate that there's a role for this class of medications to get people through certain situations, especially acutely. But just to state that there are some often overlooked effects that actually can have a detrimental effect, specifically post-concussion. So the depletion of glutathione is a big one with Tylenol. And then also with Advil, it increases gut permeability. And that is already something that we know that animal models show within 3 hours, your gut becomes more permeable. And that creates more an inflammatory response. Now, that's a good thing because the body's actually trying to heal the brain. However, if we start popping tons of Advil to deal with that headache, now I've open those doors even more and allowing more inflammation. So now you have, instead of a controlled burn, you have this big shot of inflammatory signaling molecules that are getting to your brain. So that can further impair and overwhelm the body's kind of healing processes. So I do think there's a role. What can we do? First of all, I think it's the foundations of good evidence-based concussion recovery. Start moving a little bit right after a concussion. So we know that exercise, and this is right up your alley, Cam, is actually much more evidence-based. And that actually has a benefit on blood flow and a lot of these kind of mitochondrial benefits to support some of those energy dynamic changes that happen right after a concussion. And that's actually not given. That type of recommendation is often overlooked, and people are told to still, to this day, even though the research is not in line with this, stay in a dark room, do nothing until your symptoms resolve. That's actually doing you a disservice. And then I think this is where, diet plays a role, where, again, you talk to a lot of quote unquote concussion experts, neurologists, they downplay the effects of diet. But I think this is, even though there's animal model evidence, there isn't a lot of human evidence. There's some translational research from brain protective effects of, like, let's say the Mediterranean diet, showing that, eating a plant-rich, an omega-3 rich diet has anti-inflammatory benefits. We haven't quite proven that connection specifically in concussions, but in the Concussion Fix course and in my practice, I see consistently that when people change their diet to minimize the highly inflammatory foods like pro-inflammatory, ultra-processed foods, foods that are high glycemic index, foods that are going to be really rich in carbohydrates, alcohol is another huge one that's pro-inflammatory. Eliminating those and increasing those anti-inflammatory foods I just mentioned starts recreating that inflammatory balance. So while it doesn't get rid of a headache instantaneously, it does provide the brain the tools it needs to heal and has a kind of a longer term anti-inflammatory effect. Can you think of any other acute things, Cam, that a person that has a headache can try? Like, I definitely think neck treatment is a huge area that we often see overlooked and can have some very, very fast acting anti-pain effects.
Yeah, I would say neck would be probably the number one, because most PCS headaches, and this may just be because I'm a chiro and this is what I see, but there's a ton of post-concussion headaches that are actually neck issues. And so, a really good provider can figure that out pretty quickly, right? Like, if you had a headache and I got this headache in my forehead, if I push on some muscles back here and it causes pain in your forehead, I know where the headache is coming from, right? And a lot of it's like referred pain to the head. And so treating the neck is an easy, quick fix. In a few treatments, you could actually notice a huge difference in alleviating that headache. So I would say that's up there. And similar to that, because a lot of headaches are neck related, you know, warming up the tissues helps to increase blood flow to those tissues and helps them to relax, right? The example I used today was like stretching, while you're cold and then stretching while you're warmed up. Right. If you do a workout and then stretch after the workout, you'll notice that you're much more flexible. Why? Well, because you got increased blood flow, the tissues are warmer, they're more pliable, you can move better. And oftentimes in the clinic, when we put people on treadmills, we do an exertion test called the Buffalo Concussion Treadmill Test. And oftentimes when we do that test, people will say, I actually feel better when I'm exercising. And that to me points to, okay, there's a neck issue here, because once those tissues warm up, the headaches actually get better and they feel better. So exercise would be another good one to include, because it can actually help reduce those headaches. Now you have to do it in a controlled way, because autonomic dysregulation, if you have it and you exercise too much, that will increase your headaches, right? So there's a proper way to do exercise. But even just going on a nice light walk or having a warm bath or having, like a magic bag type of like heating pad around your neck can often help give you kind of a pretty immediate relief of neck related headaches that can help you in the short term.
Especially if they're those myofascial ones that you just mentioned, which I think is the most common one. A lot of times even people will say, I have migraines. You don't really have a migraine in the acute setting. That usually sets in after, or a concussion can aggravate an underlying migraine condition. That happens
Yeah.
quite a bit. But start with, the neck connection, those cervicogenic. And, as you were talking, I was thinking, there are some nutrients that have some evidence to show that it can help with this. I think two very simple ones are magnesium and then an anti-inflammatory herb like turmeric or curcumin, which is a specific extract of that. Does have an anti-inflammatory effect, which we know this connection between the neck and the brain, it's myofascial, but there's like local inflammation that's causing muscle trigger points, and there's a tension there. There's muscle tissue that's not properly functioning and that's contracted. So magnesium has a natural kind of relaxing effect, which is in opposition to calcium and some of those more contracting minerals, which we know becomes dysregulated after concussion, especially acutely. So magnesium and curcumin have some evidence that I think could be helpful and I think are applicable. So again, not going to have that immediate effect that maybe a Tylenol or Advil at blocking pain, but it does have a role that it can, within a couple hours, for kind of mild to moderate headache symptoms, that it can have a beneficial effect in my clinical experience.
I
Yeah, I was
also,
thinking of the curcumin when you were talking earlier, because that comes up often. But I was wondering too if there were good to know about the magnesium too. Any maybe even like, are there other supplements or herbal recommendations that you would have? I don't know if like there's studies around willow bark tea or things like that that I know a lot of people tend to navigate towards.
Yeah, because there's multiple types of headaches. We're talking here about the cervicogenic type. A lot of times, if you just search headache and supplements, there's three that come up, and even neurologists are recommending these. But to be fair, they're actually studied and researched for migraines, not for headaches, but they're given and recommended a lot of times. I already mentioned magnesium, so that's definitely one that neurologists recommend a lot. And then the other two are vitamin B2, called riboflavin, and coenzyme Q10. And that's, the mechanisms of actions of each three of these nutrients, especially the CoQ10 and B2, is that they have a kind of supportive effect on our energy production at the cellular level. And we know that in migraines that can become dysfunctional. So that's one of the main mechanisms. But I find, honestly, it doesn't really have an impact on the headaches that Cam was just talking about when it's coming from the neck. I've tried it. I've had lots of patients come in. Maybe 10% of people that take these three supplements I just mentioned have a beneficial effect on their migraine. So it's worth a try. They're very safe. Lots of other kind of like general nutrient health benefits. But we're talking about what can I do if you have a kind of a more acute headache where you might be looking for something like Tylenol and Advil. Coenzyme Q10 and B2 don't have this type of effect, but magnesium and curcumin, especially if you're using a very bioavailable curcumin, so looking for one that's combined with a fat that has enhanced bioavailability, it's hard to really decipher which one that is because every single company from a marketing perspective says theirs is the best and theirs gets into every tissue. That's where I think working with a naturopathic doctor or somebody that is supplement literate, it will kind of point you into that right direction. But there are certain ones that I find do have a more efficacious effect, specifically on getting into kind of the nervous system tissues and impacting headaches.
the one thing I wanted to like also mention is that, we were talking about like migraines. I think a lot of people are actually misdiagnosed with
Oh
migraines.
yeah.
Like so many times patients will come in being like, yeah, I have migraines. I'm taking this like migraine medication. And, you ask, well, is it working? Like, and they're like, no, not really. Like I'm still getting migraines and whatever. And then I assess their neck and I'm able to completely reproduce all of their headaches by pushing on their neck. So
Mhm.
a lot of times, and I think again, just getting back to how our medical system works, right? Like these guys are trained on drugs and pharmacotherapy. So it's always like migraine has a lot of drug treatments for it.
Yep.
Cervicogenic headache doesn't require drugs. So they're not well educated on cervicogenic headache because it doesn't really serve the entire, pharmaco whatever complex you want to call it. But So if the education is mostly derived on prescribing certain medications for certain conditions, migraine tends to get overdiagnosed because there's a lot of treatment options from a pharmacotherapy perspective. Whereas a cervicogenic headache means you got to go and get manual therapy or go see a physical therapist or a chiropractor or something like that. And so it often gets downplayed. And so they'll often resort to diagnosing it as a migraine. If you look at the diagnostic criteria for migraine and cervicogenic headache, there's a very big overlap. So they look the same in many respects. And so a lot of times people end up getting diagnosed as migraines, and meanwhile they have a cervicogenic headache. And
Yeah,
so I
but
would
they
just
don't.
encourage people to explore. Just because you've been diagnosed with migraines doesn't mean you actually have migraines. It may be a cervicogenic headache that's been misdiagnosed.
Yeah, for sure.
You should probably still get your neck looked at by somebody who knows what they're doing to see if they can recreate that headache. And if they can, you've pretty much ruled out, not ruled out migraine,
Yeah.
but you know that there's a cervicogenic component at least to it.
I mean, Kim, I would argue that if you know actually headaches and pain, they're actually quite different. And I think you and I know that. There's some really important things that might differentiate that. And back to the original question you asked, Nikki, do you respond to Advil or Tylenol? Actually, is one of the things I ask my patients, because migraines generally will not, the Tylenol Advil will not touch them. These are true bona fide migraines. They have an aura. They don't always have to have an aura. Uh, and they're usually triggered by things like stress, weather changes, hormones is a huge trigger, certain foods you might trigger them. With those myofascial type headaches, you can definitely reproduce them. Migraines, you don't get reproduction based on, neck issues or pressing on neck. So I mean, I know you know this, but for everyone that's listening, those people that really understand, I think it all a lot of has to do with semantics. A lot of people just think I feel really bad, so I'm rating my headache 6 out of 6, and they automatically say that's a migraine.
Yeah.
And I don't think that. I correct them all the time.
Yeah.
Do you really have a migraine? Have you actually been diagnosed with a migraine based on the criteria? And then once we dig into it, we confirm whether it is a migraine or not. Generally speaking, migraines do respond well to the new class of those calcitonin gene receptor medications, and some of those triptans, and cervicogenics headaches don't respond to those at all, even though they might have been tried on it. So that's.
But even like, reproduction, like in the criteria, if you read the criteria for cervicogenic headache, it means your headache increases with like neck movement. And I often find that's not the case. Like people, like I'll ask them that question and they'll say, well, no. But then if I push on certain muscles, right? And I can, because certain muscles in the neck and certain joints in the neck have specific referral patterns that they go to. So for example, your suboccipitals often refer pain to the forehead and right behind the same side eye, right? So the right side suboccipital is going to refer pain behind the right eye. And people will be like, I have this like pain in my eye. And right away I go, I'm going to check the suboccipitals. And if I push on the suboccipitals and they go, oh my God, I know that pain is coming from there. Even though you feel it here, it's actually being caused by something back here. But from the medical perspective, if you look at the diagnostic, it's like pain reproduced with neck movement. And people will be like, no, I can move fine.
No.
It doesn't increase my headache when I move my neck. And that's often the extent of the assessment in the doctor's office is like, oh, does it hurt when you turn your head to the right or left? No. Oh, then it's not your neck. And that's just,
it's a great point.
That is so
point.
ridiculous because it's like, well, did you actually touch them? Did you push on it? Could you reproduce it? And oftentimes they don't even know where to push, how to push, what to look for.
They don't even look at the back. They don't look at the scalenes. They don't look at SEMs.
Even SEM refers pain into the face, forehead, jaw, everything. So
one
it's like
side,
right. So you got to know your referral patterns to be able to like actually do this properly.
Awesome. Any final thoughts before we chime off for today?
I think we covered it pretty well. I think there, like we said, to conclude, there's a role for Advil and Tylenol. I think the question we got today during our Q&A live with the Concussion Fix members seemed like a really basic one. They were almost embarrassed to ask it, where they were like, my brother asked me, is Tylenol, why couldn't you just take a Tylenol for your headache? I feel like that's just so reflective of our current kind of thought around our health, where it's like, if I have a symptom, is there an anti-medication for that symptom? So if I have depression, is there an antidepressant? If I have pain, is there an anti-pain? Well, that's what we're trying to kind of like totally reframe as part of the Concussion Fix program, and definitely in our private practices, where you have a symptom, and in this case, we're talking mainly about pain, and headaches is the main type of pain, or neck pain. Okay, what's the cause of that? Let's just not block that. And so there might be a role for a person to get through a certain situation or get through an acute type of situation, short term, very, very sporadically using it. But I think hopefully the takeaway from our conversation today is that that's not really addressing the pain. And if you're reliant on these medications all the time, not only are you kind of maybe getting stuck in the cycle of being, kind of yo-yoing back and forth and getting a rebound headache, you're actually not really addressing the root cause. So hopefully we've given people some ideas today on what they should be doing, and maybe a few natural things that if they are in pain, they could implement. Maybe not getting the acute effect right away, but the long-term benefit without the side effects is definitely a plus.
Treat causes, not symptoms.
Yes, absolutely.
Mic drop.
All right. Thanks for listening to the Concussion Fix podcast. Remember, recovery is possible and you're not alone. Have a great day, everyone. Bye.
Bye, everyone.
Bye-bye.
Thank you for tuning in to the Concussion Fix podcast. We hope you found today's episode helpful and that it gave you a little more clarity, hope, and confidence on your road to recovery. Remember, every step you take matters, no matter how small it may seem. If you feel that you could use a little more support on your healing journey, check out the Concussion Fix program. Just visit concussiondoc.io or simply type Concussion Fix into Google and read some of the reviews from people who've already walked this path. With over 3,000 success stories and an average symptom reduction of nearly 50% in just the first few weeks, it might just be the help you need to break through. Thank you again for listening. If you found value in this episode, please share it with someone you think could benefit, and don't forget to subscribe so you never miss a session. Until next time, stay hopeful, stay curious, and continuously remind yourself that recovery is possible.